Welcome, medicos. Let's dive right into this explainer. Today, we're doing something really cool. We're taking the normal healthy biological engine of skeletal muscle and mapping it directly to high-yield board pathologies. Look, we aren't just going to sit here and memorize isolated facts today. We're building a comprehensive framework. Because once you understand exactly how a muscle is supposed to work, you'll instantly see exactly why it fails in a clinical setting.
So, here's our game plan for today. We'll start with the 5 skeletal muscle traits, move into excitation and its pathologies, and then tackle contractility and structural mechanics. After that, we'll build out the neuromuscular disorders matrix, do a high-yield pathology synthesis, and finally put you to the test with the exam cracker challenge.
All right, let's jump straight into Section 1. We're starting with foundational anatomy and physiology by examining the 5 absolute, non-negotiable traits that every healthy skeletal muscle cell shares.
To be a perfectly functioning muscle cell, you need 5 core operational requirements. We're talking excitability, conductivity, contractility, extensibility, and elasticity. Excitability is simply the ability to respond to a stimulus, right? Then conductivity is spreading that signal. Contractility is the forceful shortening, and remember, muscles literally only pull, they never push. Then you've got extensibility, which is the passive stretch, and elasticity, which is that active bounce back. Every single healthy muscle cell has these traits, and as we'll see, if even one of these traits fails, you're looking at a highly specific clinical pathology.
Okay, moving to Section 2. Let's really zoom in on that first major property, excitability. This is the electrical baseline that commands the whole muscle to act. Because, if the spark fails, the engine just doesn't start.
Let's look at the action potential. This is a super tight 2 to 4 millisecond electrical firing window. It hits a peak amplitude of 120 millivolts before dropping straight into that critical refractory period. That firing level triggers at negative 50 millivolts, shooting all the way up from a resting membrane potential of negative 90. It's an incredibly rapid, all-or-nothing electrical command that dictates exactly when that muscle wakes up.
Now, for your exams, you absolutely must etch this golden rule into your memory. The actual physical pull of the muscle waits until this electrical signal is almost entirely finished. This is totally crucial. The depolarization essentially clears the runway, right? So the mechanical activity begins only when the electrical activity is hitting its absolute final stages.
So what happens when things go completely off the rails? Specifically, what if a lack of calcium causes that electrical threshold we just talked about to plummet? Well, you get tetany. That's erratic, spontaneous firing that manifests as really dangerous carpopedal or laryngeal spasms. The electrical tracing goes completely haywire, its excitability running amok. Now, the main clinical pearl to take away here is that tetany is a failure of the electrical threshold. Actually, scratch that. Let's be more precise. It's purely a threshold issue, absolutely not a structural failure of the muscle fibers themselves.
And here's another critical failure of excitability, myasthenia gravis. In this case, autoimmune antibodies physically block the acetylcholine receptors at the neuromuscular junction. The crazy reality here is that the skeletal muscle fibers are perfectly healthy. It's purely a transmission failure. The spark is desperately trying to cross the gap, but the receptors are shielded.
So how do we clinically diagnose this blockade? Well, we use the Tenzelon test, which is honestly a brilliant step-by-step pharmacological hack. Normally, the enzyme acetylcholine esterase comes in and cleans up the ACH. But if we introduce edrophonium, we block that cleanup enzyme. And what happens next? We completely flood the junction with acetylcholine. This massive accumulation of ACH temporarily overwhelms those pesky autoimmune antibodies, restores the signal transmission, and rapidly reverses the patient's weakness. It's a real game changer that beautifully exploits the property of excitability.
All right, Section 3. Let's see how that electrical spark builds into our next core trait, contractility. This is the heavy machinery that actually forcefully shortens the muscle once that electrical signal successfully gets through.
This is a classic high-yield comparison of the 2 main mechanical contractions. Let's check out isometric mechanics first. Here, the tension increases, but the muscle length does not change, so literally 0 external work is done. All that energy just becomes heat. Think of it like pushing as hard as you can against a solid brick wall, or just maintaining your posture. Contrast that with isotonic mechanics. Here, the tension stays the same, but the muscle actively shortens to perform external work. That's your typical walking or lifting a dumbbell.
Now, the raw pulling power of a muscle isn't just some random output. It's strictly governed by these 6 force multipliers. Stimulus strength recruits more motor units, stimulus frequency directly scales the force, but pay really close attention to number 3, initial length. The force of contraction is directly proportional to the initial length of the fiber. Does that sound familiar? It should. It perfectly links back to Starling's law of the heart. It's the exact same physiological principle just applied to skeletal muscle. Oh, and also keep in mind load parameters, temperature, and fiber type, because fast-twitch fibers just naturally generate greater raw force.
Time for a quick clinical pearl and myth bust regarding structural integrity, because students mix these up all the time. Extensibility is simply the passive ability to be stretched. It requires absolutely no energy. Elasticity, on the other hand, is the active recoil. It's that snapback to the original length. The crucial pathology link you need to know is that failing at extensibility, meaning the muscle physically cannot be stretched, is exactly what causes spasticity. And hey, while we're on the topic of the musculoskeletal system's structural integrity, let's clear up another highly tested misconception about the actual bones these muscles are pulling on. Yes, both of these diseases affect bone breakdown, but osteoporosis is a systemic reduction in bone density. It affects the whole skeleton. Paget's disease, however, is completely localized. It involves excessive breakdown and formation that results in enlarged, misshapen bones, but it might literally only affect a single bone, like a femur or the skull.
Moving into Section 4, the Neuromuscular Disorders Matrix. We're going to take all those individual mechanical and electrical failures and organize them into the ultimate differential diagnosis tool. Seriously, wake up if you've been dozing, because this is where you earn your points on the warts.
So, the whole trick here is memorizing this specific matrix. You absolutely need to be able to instantly distinguish Duchenne muscular dystrophy, which has sex-linked genetics and onset under 5 years old and starts in the lower limbs, from something like myotonic dystrophy. With myotonic, notice it hits in adult life, starts with tongue and facial weakness, and brings massive systemic threats. Then you've got myasthenia gravis, which we covered earlier, known for its relapsing and remitting nature, typically in 20 to 40-year-olds. Use this matrix as your primary mental scaffolding. All right, Section 5, let's take a step back and look at the grand architecture of how these normal physiological properties degrade into actual clinical diagnoses. We are fully connecting the bench to the bedside right now.
Let's connect the dots here. When normal excitability fails into a blocked signal, you get myasthenia gravis. If it fails into a hyperactive signal, you get tetany. When normal contractility and structural integrity degrade, you see muscle wasting. Those are your muscular dystrophies, like DMD or myotonic. And when normal extensibility fails, it hardens into spasticity. The big takeaway here? Pathology is really just normal physiology pushed beyond its limits.
Okay, it's time for Section 6. Let's shift gears from passively learning to actively applying. Let's test your clinical reasoning with a board-style vignette based on the whole framework we just built.
Let's break this patient down together. Cannot release a handshake. That immediately implies myotonia, right? A difficulty releasing grip. We see adult onset and tongue and face affected. Well, that perfectly matches a specific row in our matrix. Plus, the maternal uncle having similar problems screams a genetic link. So the big question is, which systemic feature is associated with this specific condition?
Using the matrix we just learned, we can rule out the noise instantly. Calf pseudohypertrophy? No way. That points to Duchenne's, which definitely doesn't fit the adult onset. Ptosis and diplopia? That's myasthenia gravis. Doesn't fit the inability to release a grip at all. Localized bone pain? That's Paget's, which is totally irrelevant here. This leads us straight to the correct systemic features of myotonic dystrophy. Cataracts, gonadal and cardiomyopathy. Boom! That is textbook differential diagnosis in action.
As we wrap up this explainer, I want you to remember that mapping normal mechanics directly to their failure states is the absolute key to clinical mastery. Stop just memorizing massive lists. Map the system instead. Physiology is your map, and pathology is just where you go off the road. Keep that grand synthesis in your mind for test day. So medicos, what physiological system will you deconstruct next? Keep studying smart, and I'll see you in the next explainer.